Hi everyone, thanks for listening to my presentations. Today I'll be talking about kidney stones and I'll tag this Lesson 1. Lesson 1 will cover symptoms, risk factors, different types of stones, and the possible causes. The risk factors for kidney stones are low fluid intake, low dietary calcium. You are expected to take normal calcium level because if you take low calcium, there will be increased urinary oxalate excretion, and that will lead to stone formation and a negative calcium balance. Also, the other rates will include low potassium, low phytate, low citrate, low fiber diet, low volume, and also prolonged immobilization will lead to an increased bone turnover and subsequent hyperoxaluria leading to stone formation. Other risk factors include high calcium intake, high oxalate, high pH, high sodium, high fructose, high vitamin C, and high meat or poultry diet. Still on risk factors, hyperparathyroidism, gout with a phase of increased uricosuriia, obesity giving hypercalciuria, diabetes mellitus with high insulin resistance, and altered urine pH, distal renal tubular acidosis, and inflammatory bowel disease, giving us low urine volume, acidic urine, and hyperoxaluria, short gut syndrome, malabsorptive bariatric surgery, acid urine leading to uric acid stones. Other risk factors include positive family history, so you need to know your genetic predisposition, prior kidney stones, because there's possibility of recurrency, recurrent urinary tract infection, if you're on medication like topiramate, pivamate, zonisamide, indinava, isaclova, sulfadiazine, triamterene, or long-term ceftriaxone. Marathon running will increase crystalluria. That may be associated with cystinuria, giving us cystine stones, and of course, low fluid intake. Different types of kidney stones are calcium stones, which will comprise about 80% of the entire kidney stones, with 70% of the calcium stone being calcium oxalate and the remaining 10% being phosphate. Uric acid stones will constitute about 10% of all kidney stones, while struvite made of magnesium ammonium phosphate will form 6%. Cystine stones will form about 4% of all kidney stones. What are the possible causes? Urinary retention and excretion of less than 2 liters will increase the likelihood of kidney stones generally. The pH that is low is acidic, leading to urethral stones. The pH that is high is alkaline, leading to calcium phosphate stones. In other words, what we need is optimum pH, not acidic, not too alkaline, or not too basic. Still on causes, uric acid greater than 800 milligram per day in men or greater than 750 milligram per day in women is likely associated with high protein intake or overproduction. Ammonia greater than 60 millimoles per day suggests that you have urea splitting organism, leading to struvite stones. Urea is high in those on high protein. Still on causes, cystine is high in cystinuria, leading to cystine stones. Citrate greater than 450 mg per dl in men or greater than 550 mg in women will increase solubility of calcium. Hence, if you have low citrate, then you have less soluble calciums, and then you are dealing with calcium stones. Increased sodium leads to increased calcium in urine, so daily sodium of 2 grams is fine to prevent calcium stones. Anatomical anomalies. Pelvic urethral junction obstruction will lead to more stones because of epistasis. Hydronephrotic varices, hydronephrotic renal pelvis will all lead to decreased flow of urine and possibility of stone formation. Lizard of reticulum, horseshoe kidney, or heterocy will all promote kidney stone formation. Vesical urethral reflux, urethral stricture, and tubular ectasia will all promote kidney stone formation. Urinary glycoproteins. Yes, deficiency of urinary glycoproteins may lead to increased stone formation, and you ask me why. They work to inhibit stone formation. So they work mainly to inhibit stone formation, but when they're absent, then there'll be easy formation of the stones. Now, Struvite stones, that is triple phosphate, commonly found in people with urinary tract infection, more in urease-producing organisms, for example, Proteus, Klebsiella, Serratia, and Mycoplasma. They have less classic symptoms, but there is possibility of hematuria, and then the individual with Struvite stones will likely have mild flank pains. And of course, recurrent urinary tract infection is a key symptom, and urine pH when measured will be greater than 7.0 plus ammonia. When there is urine pH greater than 7.0 and ammonia, that will give a kind of synergistic effect. Enteric hyperoxaluria. This is found in the face of short gut syndrome or inflammatory bowel disease. That will be leading to increased absorption by the intestine. The absence of Oxalobacter formigens, which leads to more accumulation of the dietary oxalates, is a negative factor. Normally, the bacteria degrades the oxalates, but when we are dealing with sterile gut, that will lead to oxalate accumulation, giving us oxalate stones. The cystine stones, usually found in increase in urine, that is, when there is high level of cystine in urine, giving us cystinuria. It is an inheritable situation with autosomal recessive trait. In other words, the individual becomes symptomatic when they have homozygous recessive alleles. There is what we call color problem here. That is an inborn error in transport of dicarboxylic acids. That is C for cystine, ornithine, lysine, and arginine. The decreased solubility will lead to cystine stone formation. Now, symptoms. Most of the time, kidney stones are asymptomatic. And when they are asymptomatic, most people will diagnose them while investigating the patient for something else. So when the pelvic X-ray, ultrasound, or CT is taken, then incidental discovery of the stones could be made. The asymptomatic will, however, become symptomatic in 1/3 of the cases. And when that is the case, then we'll be dealing with nausea, vomiting, fever and chills, particularly if it's struvite associated with urinary tract infection, or there is urinary tract infection secondary to the stone formation itself. We might be dealing with severe flank pain, very severe, and the pain may be radiating to the groin. There is possibility of hematuria and renal angle tenderness on palpation. The pain will be colicky in nature, waxing and waning, because viscous is affected, and in that case, might be dealing with ureter. The pain could be so severe and serious that the affected person will become restless, and there's likelihood of dysuria. So with this, I come to the end of this lesson 1. I will be publishing lesson 2 that will be all about the diagnosis and treatment of kidney stones. And the last one, which will be lesson 3, will be all about the prevention of kidney stones. So thanks for listening. Kindly remember to share and subscribe, and be waiting for lesson 2 that will be on treatment of kidney stones. Thank you, I appreciate it.